Hello, everybody. Good morning or good afternoon, depending on where you're joining us from in the country. Thank you again and welcome. Welcome to our first session of the LC. We're very excited to have you all joining us today. Before we begin, I'm just going to kindly ask all participants to please mute your line. Thank you. And I do see that we still have some participants joining as well. So let's begin. Thank you again. And today we are going to begin our first session on the Learning Collaborative on exploring cultural competence and humility in the care of HIV patients.
Progress.
So in today's session, we will be discussing about reducing stigma and discrimination in health in patients. Apologies. And then just before we continue, this is just a kind of reminder to all participants that you need to please mute your line, or your line may also be already muted upon entry. Please make sure that you engage in the chat if you have any questions or any comments. So throughout today's session, we encourage all participants to engage in a lot of activities that we're going to be doing, and you can do so verbally or in the chat. So raise your hand if you would like your line to also be unmuted. This meeting is being recorded, and the slides and recording will be sent to you all via email after this session. So here we have some background information about the National Center for Health and Public Housing. The mission of NCHPH is to strengthen the capacity of public housing primary care grantees and other health center grantees by providing training and a range of technical assistance. NCHPH is a project supported by the Health Resources and Services Administration. It is also a national training and technical assistance partner that is 100% financed by this grant. Presented today are those of the author. This is we're going over some of our activities. So today with us, we have Dr. Jose Leon, who is the Chief Medical Officer at the National Center for Health and Public Housing, and myself. My name is Filipina Slovo, and I am the TTA Manager here at NCHPH, and I will be being to facilitate today's session along with Dr. Jose Leon. So before we continue, here we have some background information about those health centers that are close to public housing. According to 2022 health center data provided by HRSA, there were over 1,300 FQHCs that served to 30.5 million patients. Of those FQHCs, 483 were aided and immediately accessible to public housing that served to 6.1 million patients. And also 107 public housing primary care grantees served to over 930,000 patients for 2022.
I'm sorry, Ms. Pineda, your audio is really bad. None of us can understand you. I'm not sure if you guys are monitoring the chat or not.
Okay. All right, thank you for letting me know. Let me see if I can.
Yeah, I can take it from here if you're having some issues. All right. Hello, everyone. My name is Dr. Jose Leon. I am the Chief Medical Officer here at the National Center for Health and Public Housing. Thank you so much for joining us. We are going to discuss a really interesting topic that is affecting not only patients living with HIV, but many of our patients are somehow stigmatized due to different circumstances. So it's a topic that is relevant. HIV probably is the most stigmatized condition that we can see, but at the same time, it's not the only one. People who are obese also have issues with the stigma, people with diabetes, people with other STDs. So let's make sure that we have a really good understanding, and I really know that we have a variety of people attending this webinar. We have chief medical officers, we have nurses, we have people from federal and state organizations, and all of us have different backgrounds. So let's make sure that we are respectful with the information that is provided by everybody. Some of us may have a better understanding of the topic. Some probably this is the first time they are going to discuss cultural competency. So let's make sure that we are respectful and we are all learning from each other. So next slide, please. For today's session, we have 3 learning objectives. We are going to define cultural competency and humility. We are going to describe the impact of cultural competency and humility on HIV patients. And we are going to develop individual and institutional strategies for creating cultural competent environments. Next slide, please. So we have an icebreaker here, since this is a learning collaborative, and the idea is to have an interaction and communicate each other and making sure that everybody has a really good understanding. If you have some strategies that you would like to share, or if you have some challenges as well, please, this is the right place where we can have this conversation. It's not just NCHPH talking, but you and others have the opportunity to chime in on this particular topic. So this is our icebreaker for today's session. What 3 items would you bring with you on a desert island? So if you were on a desert island, or you were somewhere, on a desert island, what items would you love to have with you?
Hear me?
Yeah, we can hear you, Fide.
Okay, now?
Yep, better.
Great. Okay. So, what I would think of bringing like a pot so I can boil my water and keep myself hydrated in case of anything. That would be one thing. Another thing for me would be maybe a knife. And then I can't think of a third one right now. I'm sure I'm gonna get some good ideas here in the chat.
Yeah, I see outfit, net, and water. And I see ice cream, book, and more ice cream. And honestly, this could be a desert island, but nobody said anything about electricity. So probably I could have my laptop, my phone, and some connection to watch TV. So, but in reality, this is just to have some fun and just try to make sure that we develop some communication. So thank you so much for participating. Also, please let us know your name, your organization, and your title. That's going to be very helpful to see who is attending this webinar, and to make sure that we have the variety of attendance that we are supposed to have. Thank you so much. So next slide, please. When I was preparing some of these slides, I was reading and reading about the connection between HIV and the LGBTQIA community and all the risk groups that we know, sex workers or those who are drug addicts or who have any substance use disorder. and all of them were linked to HIV risk. And this is an equation, and you know that math is a perfect science, right? If there needs to be just one item that is not true to make this equation wrong. So everybody has this understanding, at least out there in the community. And if they see someone who is a bit different, or at least it doesn't follow the same pattern, the same cultural pattern, we stigmatize this person because of the language, because of how the person looks, because whether or not this person is overweight, because this person has a different color of the skin. So is it the same? Is science, is the medical science a perfect science? So let's take a look at that. So could you advance the slide, please? So is Magic Johnson part of the LGBTQIA plus community? He's an heterosexual who was one of the first to say that he was that he had contracted HIV. So just by looking at this, we can say that we cannot stigmatize. We cannot say somebody is part of this group, and therefore this person has or is at risk of having this condition. Next slide, please. Another great example, and I am quite sure that you are all aware of Ryan White. This kid contracted HIV by a blood transfusion because he had hemophilia. And so let's make sure that by just looking at these two examples, we understand that we cannot categorize everybody into the same bucket, because that's not what we have to do when we see patients. Also, we talk about patients and stigmatizing patients, but in reality, we healthcare professionals are also stigmatized. I am quite sure that you remember the COVID-19 pandemic and how healthcare workers were stigmatized, and how people were trying to stay away from healthcare workers because they could transmit COVID when we didn't have the vaccines and when we didn't have any other medication to treat the condition. So everybody somehow has dealt with stigma and other issues that are affecting how people perceive who we are and where we are and what we do. Also, there are several types of phobias, if I could say. Patients can develop phobias against healthcare professionals as well, and that is called iatrophobia. And when we do something wrong, or when a patient perceives that we are doing something wrong, that patient is afraid of coming to any of the clinics or to have any of the screening tests that they need to have. So this is a two-way type of communication, and by being a two-way communication, either we are stigmatizing people, or we can be stigmatized by how we perceive people. Next slide, please. Next slide. So we are going to have different conversations. This is a 4-session learning collaborative. In our second session, we are going to have a health center serving over 15 different populations in the area of San Diego, who are going to, and the person who is going to present is going to provide some information about what they do regarding cultural competency and cultural humility. But this one, and I this particular session is more like an introduction to the topic, so please bear with me for a moment. Probably all of you may know the concepts of cultural competence and cultural humility, but we cannot start without having the basics and establishing the background information that we need to then discuss the strategies or challenges that we have. In regards to HIV, this is the latest data from CDC. And as if we see the chart, the male-to-male sexual contact continue to be the main form of transmission, but that doesn't mean that is the only way that the condition is transmitted. 22% is of heterosexual people are also contracting HIV due to different circumstances. So we cannot say, we cannot talk about HIV being just linked to these at-risk populations. That's not the case, and that's something that we need to have in mind. And if I can transmit that to all of you, and that's the goal of this session, I would be glad to hear that we understand that HIV is not equal to the LGBTQIA+ community, is not equal to those who are drug users, is not equal to those who practice or who are sex workers. So let's make sure that we understand that. If we understand that, we have created the background that we need to deal with our patients and to provide the care that they need. Next slide, please. Now, if we look at minority populations, Latino or Hispanic and Black or African American continue to be the two ethnicities that are more likely to contract HIV. But you know, we also see that 25% of white can also have or are HIV positive. So let's again, we cannot include everybody, you know, or assume that because somebody is African American or Hispanic, that person is more likely to be HIV or to have or to live with HIV. So let's make sure that we see that there are other races and there are other ethnicities that also can be involved and can be affected by the condition. Another thing that is curious to see, and when you see some studies on sociology, we tend to say race and ethnicity, and in reality, when you see some of these research studies from people who really do all these things about ethnicity and race, they say that there is only one race in the world, and that's the human race. And that we have different groups, you know, living in different parts, but in reality, we are all one. So that's another way to see it. And that's another way to analyze all these situations that we have, that we encounter when we have communication with our patients. Next slide, please.
Sorry, Dr. Leon, may I just do like a quick technical, just take care of a technical issue here real quick?
Sure.
I'm not gonna take that long, okay?
So sorry about that. We are experiencing some technical issues, but thank you so much for being with us. It's my understanding that all of you somehow are very interested in the topic, that some of you are experts trying to get additional information. And it's really a good opportunity to learn from each other. As I said, we have people from different backgrounds. We have doctors and CHWs and nurses and people from federal and state organizations, and everybody is interested in this particular topic and see how we can help our patients, how we can improve the services that we provide to our patients. Remember that we have a mission, and the mission is to stop the HIV epidemic, and we are not there yet. There is a lot of things that
Yeah,
we
the
need
other
to
thing I just wanted to offer you is that we do now have the ability to text using a texting service called Hi Marley. And that's kind of
Sorry,
to,
Michael, but
give you a text
can you mute your line, please?
Looks like you already gave your consent to screen.
There we go. So if we move on, as also we know that the southern part of the United States is more affected, or the people living in the southern part of the United States is most affected, or more affected by HIV due to different circumstances. I would add, in addition to sex, race, and ethnicity, all the social determinants of health that affect this part of the United States. However, we can also have other cases in the West, in the Midwest and Northeast. So we cannot say that it's just located in the southern states of the United States, and we need to create awareness that we can find issues everywhere in the United States, including the U.S. dependent areas. If we have friends from Puerto Rico, for instance, they know that HIV is a huge concern, and they are doing a lot to trying to prevent the transmission of HIV and work on pre-exposure prophylaxis, on preventive measures, on screening. They do a lot on providing treatment to patients, which are the pillars of the initiative on stopping the HIV epidemic in the United States. Next slide, please. This is HRSA's information and data. HRSA released last year a patient health center patient survey, and there is information. The very first table that you see, that is from UDS, the Uniform Data System, but below you see what patients are saying, whether or not they have been tested. And if we take the last 3 years, and these are related to new diagnosis linked to care, we see that we are not moving enough, that the number of patients who are HIV positive are about the same. And when patients are asked whether or not they have received or they have been screened or tested for HIV, over 45 or almost 45% of them say that they have not received any screening test, or they have not, or the test have not been offered to our patients. So there is a lot that we need to do. Is not just the screening. Sometimes there are other issues affecting our patients. There is this concern in some of our patients, and because they can be either stigmatized, or they can be
yesterday.
or they can be either
Literally just like so many things.
and they can either be
Nothing crazy, but just like things just kept stacking up. Like,
second, please let me mute. Okay. Sorry, guys. So let's make sure that we also, if we are trying to put in place a program or a strategy to address cultural competence and cultural humility in our community, and teach some recommendations or policies to our staff, we cannot ignore the data. Is all the very first step that I recommend is to go and see the federal data and the local data. What is happening in your community? What do you need to address? Who is in my community and what they are doing? If we don't have that information ready, then it's going to be very difficult for us to establish some policies on cultural competence and cultural humility. Next slide, please. Same information from HRSA's study. This is the patient health survey, and this is a broken down by race and ethnicity. And if we see Hispanics are about the same when they say that whether or not they have been screened, around 50 and 48%. The non-Hispanic white are not being screened at the same rate. Over 50% of them are saying that they are not being screened. And the non-Hispanic black, they are about 72, 73%. And the people who were interviewed are saying that they receive a screening test. I cannot say that, oh, you are black, you are more likely to have, so let's screen the black patient or the Hispanic patient. I don't think that is the case, but it's interesting to see that Hispanics and blacks are screened, and they are more likely to be screened when you compare them to the non-Hispanic whites. Next slide, please. So we have different, moving on the topic, we have different, the practice of medicine includes the concept of culture, and we have patients from different cultures coming to our community health centers, and we need to learn from them, specifically some of the more important aspects of their culture. When you say Hispanic population, for instance, it's very, very difficult to say that all Hispanics are the same and they share the same culture. That's probably not right. The same when you talk about our Asian population, our Asian Americans. And someone from Japan is different from someone from China. Someone from China is different from someone from Thailand, and they have different culture and they have different habits and they have different conditions as well. Next slide, please. So we can analyze one by one, the way that they look, how they dress, whether or not they have eye contact, and all of that. We can learn all of that by just having a conversation with our patients, making sure that we understand our community, making sure that we know who is coming to the clinic. Next slide, please. Regardless of who's coming to the clinic, we all share over 98% of our DNA. So we are talking about different cultures, we are talking about different ethnicities. In reality, and going back to the study that I mentioned, there is only one race, and that's the human race, because research studies have shown that regardless of where are you coming from and who you are, we are sharing 98% of our DNA is about the same. So that is what we need to know about cultural competence. I am quite sure that all of you are very, very familiar with the definition, and making sure that we know and we understand the norms that are around our patients and that give a shape to their to the customs, then we are going to be more cultural competent. Next slide, please. Now, cultural humility is to stop all the prejudice and everything that we know or that we think we know about the people or the population that we are helping, and then practice some self-humility, making sure that we have that awareness. We are going to see other slides when it's going. We are going to understand that it's not sometimes something that we can control. All of us have some type or we stigmatize people somehow the same way that they are stigmatized us. But making sure and knowing that we are different, then that is we are going to start practicing cultural humility. Next slide, please. Now, cultural competence and cultural humility are linked to a stigma, and specifically to the HIV stigma. And HIV stigma is all the negative attitudes and beliefs about people with HIV. And we are not talking about positive things. We are not talking about, I know people who are living with HIV and they are very smart, or they are, people very knowledgeable, nice people to talk to. No, we look at the negatives, at the negative attitudes or characteristics of these people. So we start stigmatizing by put them into some groups, like the only people from the LGBTQIA plus community can have HIV, or sex workers, or those with substance abuse disorders. We also discuss whether or not they are doing good or bad in their life, and that's something that they deserve because of what they do. That's another way that we stigmatize people. And we're talking about choices as well. This person has developed this condition because they deserve to have it. They are in risky behaviors. They do all these kind of bad things, and therefore that's the reason why they got HIV. That is negative attitudes, and we are not looking at the positive things that people can have, and that is what the stigma is about. Next slide, please. Next slide. So what causes a stigma? There is several information about fear. When the epidemic started in the early 80s, nobody knew anything about HIV or what HIV was. And that type of lack of knowledge and people believe that once you were diagnosed with HIV, you were going to die. So fears and the lack of information are the roots of HIV stigma, not only in the United States, but around the world. Next slide, please. So there is nothing better than a picture to understand exactly where the stigma and the fears are coming from. This is an excellent video that it shows why sometimes we stigmatize people because we either don't understand the condition or whether we are afraid of the condition. Can you play the video, please?
Can you hear?
No video.
Nothing?
Nope. But this is a video that is available on YouTube. If you go to the HIV fears and you do that search, you will find some advertisements, about causing fear instead of causing, a positive message on how to prevent the condition. It was more like, if you are diagnosed with the disease, you are going to die regardless of who you are, what your religion is, what you do in your life, you are going to die. So that's the reason why HIV is the most stigmatized condition, because we didn't provide positive messages, but we encounter all of these announcements and publications, basically providing fear to the population. Next slide, please. So sometimes we believe that, I stigmatize or I have some bias, and that's something that I control. In reality, this iceberg model shows that there are some part of the brain that we cannot control, and that we have what we call unconscious bias. And let's make sure that we understand that we are not, this person has bias or has a stigma, and the person is, you blame that person for that in particular. But in reality, our brain has different places, where we learn and we show what we learn, but at the same time, there are some processes that are automatic and that we don't know exactly what is happening and why we are stigmatizing people. So if we understand that, that's another way to understand that sometimes it's not that you are stigmatizing, is just that due to different circumstances, your brain is perceiving what is happening in the environment in a way that is probably is not right, but you can do some choices, right? Making sure that you understand that this is not right, that this is wrong, and I am going to change, and that's part of the cultural humility definition that we discussed. Next slide, please. There are several ways how we discriminate or stigmatize people. This slide has some examples, but there are some healthcare professionals refusing to provide care or services to a person living with HIV, or we socially isolate a member of the community. And we refer with other names, like positive or HIVers, to a patient with HIV. So that's a type of a stigma, and that we need to make sure that we do everything that is possible to address this issue. And sometimes we can educate ourselves and we try to be more cultural competent, but we work in an environment where our patients are not only with us, but with other members of the clinic who also need to be trained, who also need to understand that anything that a patient perceives as negative is going to cause issues for this patient. And the patient may not come to the clinic not because of us, but from somebody else who was in the clinic and who had no idea about cultural competence. So let's make sure that we train, if we understand the topic, let's make sure that we train others and that we show them how to refer to patients when we are dealing or caring for patients, specifically for our patients experiencing HIV. Next slide, please. There is a checklist. If you are familiar with the AIDS Education Training Center, they have a really nice table with a checklist that it can help us to see whether or not we have cultural sensitivity and how we can, or what we can do to be cultural sensitive. Again, we are going to share these slides in case you want to see the checklist and you see whether or not you can check yourself, or you can check other members of your team and check their cultural sensitivity. Next slide, please. Also, SAMHSA has another checklist. This is more mental health related, but it's a really good one when we address some of the issues and some of the cultural issues of our patients, and making sure that we understand what we need to understand in order to provide cultural competent treatment to our patients. And this is more related to substance use and substance abuse disorders, but it can be adapted to our needs, and making sure that we have a multicultural intake checklist as part of the training for our team and our health center staff. Next slide, please. There are several ways that we stigmatize people. Ageism is one of them. There is the concept that growing old is bad. And we have all these type of ads about creams that help to be younger, And in reality, that is a way that we are showing people that is not good, to grow older. And that is one way that we do it, and ageism is mentioned in several studies, and specifically there is an NTAP, National Training and Technical Assistant Partner, and they have really good training on how to deal with ageism and how ageism affects, you know, our senior population. But the body size, how the people look like, the mental health status, the sexual orientation, and even the housing status are reasons or issues why we are stigmatizing our patients. Next slide, please. There are several types of stigma. We are going to go over all these type of stigma in future sessions, but the public stigma refers to what people think, how people perceive others, whereas the self-stigma is how I see myself, who I am, and what I'm doing. And the perceived stigma is what I think others think about me. You know, is how the public stigma is affecting me. The label avoidance is basically when we see someone and we try not to be in contact with that person or to stay away from that person. I had the experience during COVID. I was at the supermarket and somebody was wearing scrubs, and people dodge this person, you know, without knowing whether or not he was a healthcare professional, you know, and they were just labeling this person, and oh, this person may have COVID or has been in contact with someone with COVID. And in reality, it could be somebody, you know, like a vet, for instance, or a vet assistant. But we saw the scrub, we saw the way that this person or what he was wearing, and everybody was trying to stay away from this person. The structural stigma is when the institutions have a stigma. We have heard about issues in the workforce and who they hire or who they don't hire. The health practitioner stigma that we have already discussed. And the associative stigma is like, if you are with this person, then you are similar to this person, and therefore you can have that condition. So that is more a philosophical issue. Is there is something in philosophy that that you say, if you have two sentences or two variables and they are right, so the third one is also right. Like let me do it for instance. All HIV people, or all members of the LGBTQ community are at risk of HIV. And John is part of that community. Therefore, John is at risk. That's a fallacy, right? So that is what associative stigma is about. Next slide, please. So we are going to have some breakout rooms. I'm going to stop for a moment. We had to go over all the concepts, and we had to give the overview. I promise that the other sessions are going to be, we needed to create this background information. But I'm going to stop talking for a moment. We are going to go to some breakout rooms. We are going to give them some sentences, you know, or what people can say about people with who are HIV positive, and we are going to say whether this was public stigma, self-stigma, label avoidance, perceived stigma, and all the stigma definitions that we discussed. And we also would like to know, how would you help these people, you know, when they have this low self-esteem? Because what we're creating with our patient, to our patient with our comments, is that we are lowering their self-esteem, and we are creating some issues, mental health issues in our patients, either anxiety, depression, or any other condition that can affect our patients. But Fide, we can go to the breakout room for a moment, and you know, we can give 5 to 10 minutes.
Sure.
And then we can come back and discuss, you know, what we have learned.
Okay. So I'm going to also post the other two questions in the chat. That way, each room has their own question. Okay.
Okay, perfect. All participants have been given 60 seconds to leave the rooms. Why, Fide?
That is odd. Let me see. I've never had that issue before, but okay. They're being sent to their rooms. Anyone having any issues with the breakout rooms, please let me know. Otherwise, then we're just gonna do the responses without the breakout rooms. They're all open now, Dr. Now.
Ours just ended. Our breakout room.
Right, let me just close all the rooms. My apologies. Today I've been having just a combination of all sorts of technical difficulties. But
Can you send them
No
back
worries.
to the breakout rooms? I'm sorry. Can you send us back? Is that possible?
yeah, they're coming back now.
Okay.
You just have to wait a few seconds.
You said that they're going to close in 33 seconds, Fide.
Yeah.
Well, it seems that we're having difficulties, guys. So my apologies for this. I think that we can do it here and we can have a brief interaction. And the first two comments that we have here are from two different people. The very first one is saying, "I'll never forget it. I just wanted to die. I just felt that I was useless and I shouldn't live. And I felt real disgraced, ashamed. I just felt bad. Other than feeling bad mentally, I felt bad physically. It took me a long time. I stayed in denial for a long time." And this is someone who had been diagnosed with HIV. Just diagnosed with HIV, and another person also said most employers would not employ me because I am HIV positive. So what type of a stigma these two people experiencing, and how we can help them? If you were the provider and you had this conversation with your patient and your patient were saying this, what would you do to help your patients?
And also feel free to participate verbally. We would like to hear from you.
I think the one on the left is self-stigma. They use a lot of I statements. And I would present them with, research and facts that, people can live a healthy, normal life. Even with HIV, it's an okay thing. It's not bad. It's okay to be you in all that involves.
That is great. Thank you so much for that. I appreciate, and you're right, that is a self-stigma issue. And the best way to help our patients is to let them know that that HIV is not a death sentence anymore, that there are several ways that we can that we have different treatments, that if a person viral load is minimal or undetectable, that person cannot transmit the condition. So that's what the type of messages that we need to give to anyone who is experiencing this type of a stigma. What about the other one? Most employers would not employ me because I am HIV positive.
So we do have some responses in the chat. Somebody said A for the second option and B. Would anyone like to chime in?
And this is basically a combination of self-stigma and perceived stigma. Is not only affecting me the way that I think people are seeing me as a patient, but at the same time, that's what I perceive, that I would think others are thinking about me. So this is a combination, and again, we need to make sure that when we have perceived stigma, that person can also be experiencing some issues, mental health issues like anxiety or depression. And if somehow you notice that the patient is being depressed or is experiencing anxiety, you need to work with your mental health or your specialist in your clinic, or refer this person to a mental health specialist, so these people can have a conversation and making sure that they receive the mental health help that they need when we have these type of situations. Next slide, please. So we have another two. One is my neighbors wouldn't like living next door to me if they knew I had HIV. And they think people with HIV should live in separate houses. Any idea? Any? B and C?
Mhm.
Yeah, Darla. Basically, this is B and C as well. You know, is how people are, you know, how we perceive people are seeing us, and at the same time, we are internalizing, you know, the issue, and then we are making ourselves, you know, victims of how others see us. So you're right. This is more a B and C type of issue. Next slide, please. Let's take a look at the one on the right. People say she got AIDS. Just stay away from that person. Any ideas?
So we have a combination of responses D and G.
Okay. Yeah, I see that there is a you know, different opinions, and here the idea is I think that there is no right or wrong answer with this. To me, this is more like public stigma. This is according to the people who put together this training, and they refer this, at least the one on the right, as public stigma, and Christian is right. This is something that when we see the people say is basically, you know, how we are stigmatizing people and how the community sees us. And that's another type of stigma. But at the end, there is only one victim, the one person who has been stigmatized, regardless of the type of stigma that we see here and whether or not these are different stigmas. There is just one person who is suffering the consequences of how we see them or how the society sees them, and is the person who is perceived or the person who is linked to the stigma that we all have against this person. Next slide, please. There are some theories to explain stigma: the labeling theory, the social identity, and the terror management. The labeling theory is basically what we always try to label someone and put someone in a bucket. If the person has, for instance, diabetes, we say, okay, this person has diabetes and this person is probably obese, this person eats a lot, this person doesn't exercise, this person doesn't follow the instructions. Same with our patients experiencing HIV. We say all the negative stigmas that we have already discussed. The social identity theory is similar to the stigma that is the public stigma, right? How we identify people, what we're saying about people, how we are if somebody calls someone, you know, an HIV patient or HIV person, we learn, you know, to call this patient an HIV people on HIVers. So that is the social identity. And the terror management theory is when you hear about somebody who is experiencing something similar to you, and then you say, oh, can this happen to me? Am I going to be like this person? So you are also doing some type of terror management. No, I don't think so, you know, because he is a drug user or has the substance use disorder. And even though I have a substance use disorder, I am not like him. So that is what is called terror management theory. Next slide, please. So let's another opportunity to discuss the harmful effects of a stigma. If you could use the chat box and say, what do you think is going? I mean, when we are stigmatizing our patients, what are the harmful effects that we are creating on our patients? Social isolation. That's correct, Michael. Loss to care. Chelsea, thank you for the social isolation. And Michael, loss to care. What else? They won't return and missed out on care they need. Correct. Somebody else? It not only affects their mental health, but also prevents them from reaching out for treatment or a low self-esteem. All right, let's move on. Next slide, please. So basically, there are three things that we need to be conscious about, and if we are stigmatizing our patients, the patients are not going to come back, and they are not going to access treatment. So we are creating mental health issues on our patients, and they can have risk of personal safety. Suicide is one of the biggest concerns when we are stigmatizing or we are bullying people and lower quality of care. Next slide, please. So this is how we develop cultural competence. And Fide, can you move to the picture, and we can finalize this session with the picture. We are going to follow all this information. Again, in session 2, we are going to have health centers, health center who is, and the person is the HIV coordinator at La Maestra Community Health Center in San Diego, and they're going to share their experience with their patients and the cultural competence policies that they have in place. And we've been talking about that we need to be very cultural competent, and everybody needs to be aware of it. And the doctor has different posters here, but what is wrong? So who can tell me what is wrong here? Or what is happening with this patient? Anyone?
Would like to select a volunteer real quick. Hopefully you're available to participate. Ashley Linares. Okay. We have another volunteer who would like to chime in. I know from my perspective, Dr. Leon, what I do see something wrong here is just like the facial expressions from the people that are in the clinic. They seem to be perplexed about seeing the woman in the middle. I don't know if there may be a confusion there or something like that.
Yeah, what we have here is an example of a social, of a sex worker, coming to the clinic probably for her HIV screening, trying to get some condoms from the clinic, and we see that not only the patients, but the nurses are looking at her like she had, she was a monster or somebody who shouldn't be there, even though they are promoting in the clinic and they have some posters about you don't get HIV from hugging someone. Use condoms every time you have sex. So this is something that sometimes happens different levels that we are promoting, and we are trying, and we're saying that we are going to help our patients, that we are trying to decrease the number of cases, that we are providing education, and yet we are still stigmatizing our patients. So that is what is this picture shows. And in reality, it happens to our patients. Here, the take-home message is that all of us somehow stigmatize people or try to put them into some categories, but we need to be humble enough to make sure that we remove all the negative ideas that we can have regarding someone who is not sharing the same patterns of culture or norms that we follow, and making sure that we understand them and that they are people who deserve to be screened, who deserve to receive care, regardless of whether or not they have a condition, and not only HIV, but it can be any condition. People with disabilities are also stigmatized. People with senior people are being stigmatized in our community. So let's make sure that we address that we have a better understanding of what we're doing, and follow some of the policies that we have in place. I recommend to go over the checklist that we showed. And we are going to stop here for is past the hour. So thank you so much for being with us. And next time, we are going to have our health center participating. We are going to go over some case studies and see what we can do from a personal perspective, from a institutional perspective. Thank you so much for being with us. We apologize for the technical issues that we had, and thank you and have a great afternoon and enjoy the rest of the day. Thank you.